So I'm Madeline. Hey, I'm one of the PGY2s at the HCA program. Thank you, Dr. Cohen, for this case. So we have a 35-year-old male who presented yesterday morning reporting that he woke up with poor vision in the left eye. Prior to that, vision was okay. Past medical history is unremarkable, although his blood pressure is 154/115. Vision in the right eye was 20/16 J1, and in the left eye 20/40 J16. IOP was 22 and 18, and lens was clear, no uveitis. And here's the first photograph.
So this is a fundus photo of the left eye. Or I guess it's combined. So the right looks okay, but the left, there's the media looks clear. Is this
IR.
IR.
Yeah.
I
thought I had a color. I didn't have a color in this one.
Is this just a combined image where I'm?
No, it's a right and left eye. So you got the right eye and your left eye.
Okay.
They're just kind of smushed together, but it's two different pictures.
Okay. So the media looks clear. The disc looks sharp and flat. The vessels look normal caliber. And there is a larger, I guess, hypofluorescent area in the macula.
Hyporeflective, yep.
Reflective.
Left eye.
It's a cyclops.
Okay, and then
And so now this looks like the FAP. So the right eye looks unremarkable. The left has an area, again, a larger area of hypoautofluorescence in the macula with kind of like concentric, almost hyper-autofluorescent areas. Yeah.
okay, and then there's these smaller dots as well that are hypoautofluorescent. And the OCT MAC in the right eye.
Since you have the right eye, it looks unremarkable, good architecture, no edema.
Left eye.
The left eye, there is a significant kind of fluid, subretinal fluid, right kind of under the fovea.
There's also these little kind of punctate hyperreflective areas as well within the subretinal fluid.
Outer segments. If you go back to the former OCT, now that you've seen that eye, is there anything in this eye that looks a little bit off to you?
Maybe some like extra pigment migration.
Go back to the previous one. No.
In some of the kind of middle retinal layers.
Yeah.
How about the choroid?
Oh.
Yeah.
Like a thick choroid.
Yeah, this is a really thick part.
Yeah.
So that's an EDI OCT scan. So you can see the card. So we always get EDIs of both eyes when we see something like this.
How thick should the choroid be? Thickness of the retina?
Yeah, it's 200, so it's about 250 microns. So the central thickness should be about 250. The thickest part, which has a name, which we'll cover in August, but I forget by May. Perifovea or paraphobia is about 500. So you got 250 and 500. It should be somewhere between there, but closer to the 250. This one's probably above 500. It looks like it's more like 600 almost.
Okay. And then there's a few, this is just the right eye. There's just this one slide, but then there's several for the left side for the autofluorescence. Or so that, sorry, the FA.
So we have, it looks like the late kind of venous phase. I can't really see the time, but the right eye looks unremarkable to me. I can't really see the time.
It's like 1 minute and 5 minutes.
1 minute and 5 minutes. So like the recirculation phase on the right. Is that correct?
Yeah.
And then here's the left eye.
And can you read out the times? I can't.
Yeah, this first one, sorry, it's kind of cut off, but it's 17 seconds. And then the second one is 19 seconds.
You don't really need them. You shouldn't need the times.
So, I mean, you can see that it's the arterial phase, and then it looks like lack of like blood flow through the arterial phase on the left. And then on the right, it looks like the AV phase.
So in very
In certain
early,
areas where it's not going through.
you can get patchy choroidal filling because the choroid fills lobularly.
Mhm.
So that dark spot infratemporal to the fovea in the left image, and the dark spot superior to the fovea in the left image, a little darker at the very edge of the camera,
Mhm.
those should fill in. That's probably just patchy choroidal filling.
Okay.
But then the center is kind of where the action is. And there's not much going on right now.
Okay.
And so. Just like later stages of the FA. I'm not really sure what I'm specific about. Just like the large kind of hyperfluorescent area there in the center.
This
Mhm.
is. We were trying to combine.
Yeah, so
This is as good an example as you like to find.
okay, so this looks like pooling,
All right.
because it's like edges
It's progressive
progressive.
and it's
Yeah.
fuzzy.
Mhm.
You see the difference with an RPD with the edge?
So, how would you differentiate, and sorry, this is a dumb question, but how would you differentiate that from leakage? Is leakage would be more irregular?
It's almost like
Getting some
how much do you use the
like that.
diagnosis you think it is to then determine.
Exactly.
Because that's what I think.
But
Or just use the OCT. This is
Right.
Yeah.
to do with the old old fashioned way we had to treat, which was laser.
Yeah,
You know, because you would see the classic and then we got more sophisticated and we saw this, we saw areas of with sort of glow late, call it what, not classic, but non-classic, what do you call it?
I think
So you treat
typically,
the classic and you get a recurrence to a big cult.
I think typically for leakage, so if fluorescein exits the vessels, it's leaking, right? So fluorescein should stay intravascular the whole time in the retinal vessels. In the choriocapillaris it leaks, in the retinal vessels it should never leak. So fluorescein accumulates anywhere it's leaked. I think we usually use leakage if the borders fuzz out. So typically we use it if it's leaking into the vitreous. So neovascularization leaks like crazy. Sometimes you'll get sort of a diffuse leakage in uveitis. So I think leakage is that mostly. So this is kind of leaking because it's an expanding spot. But then if you look around it, it's leaking into a puddle of fluid. So it's pooling.
Yeah.
The leakage is pooling. So that's about as good as you're gonna get. I don't think people are gonna push on it that much. Honestly, people are hardly doing fluorescein anymore. I wouldn't worry about the leakage that much. But the one thing is you can't call leakage or pooling or any of that stuff up in one image. So you can't just look at the left image and say, oh, there's leakage, because you don't really know. You have to look at it to see if it's getting bigger.
Yeah, because until it reaches the borders of the pool,
Right,
it's leaking.
it's leaking.
Mhm.
And you could say neovascularization is pooling into the vitreous. But the vitreous is just a really big border. It's all eye.
Yeah.
Okay, so this is at 1.5 minutes. And then this last one is at 6 minutes. So I think, or 6.5 minutes. So I think in this case, you could say this is pooling. It doesn't really expand much further than that.
Go back one,
Yeah,
go back one.
So that's.
You can actually, I think you
Leaking
can
into a
see the
pool.
edge of the NSD where it's actually, some of the dye is around that edge.
you can sort of, it's funny, you see it in that image, but not the next one, which I don't know.
Yeah.
what it is.
It may be,
Yeah, the one on the right.
this one is less exposed than the next one.
What's NSD?
Mhm.
Neurosensory
Neurosensory.
detachment.
Okay. So kind of similar in this last one. And so to kind of summarize the findings, We have this OCT MAC with significant subretinal fluid here. And then this kind of expansile dot pattern with the FA. So do you have a differential diagnosis?
So in this like 30-something-year-old man, my first thought would be CSR or CSCR. If he had maybe diabetes, maybe this could be diabetic macular edema or maybe like hypertensive.
He had high
Retinopathy
blood
of
pressure.
some sort. Yeah.
I mean, it could be hypertensive.
50% of the population.
Wasn't he 150 or 100 something? though?
Central
110?
Serous.
Yeah. Is
His
it,
diastolic was touched. I mean, I don't think it was that.
Okay, good, yeah. So CSCR is at the top, and then also exudative macular degeneration, polypoidal chorioretinopathy, and then kind of any other cause of subretinal fluid accumulation or a serous retinal detachment. Some of these inflammatory conditions, you might expect to see vitritis though, and the vitreous was clear in this case. And then at the bottom, I did put rhegmatogenous retinal detachment. So just making sure that you look and ensure that there aren't any tears. However, the FA pattern is pretty classic for CSCR.
The Voigt-Koyanag Harada syndrome, in my opinion, can be viewed as just diffuse central serous.
It looks very close. That's the closest thing. I've yet to see BKH. That's like on my bucket list. I'm not gonna
Really?
We'll send you. We'll see how serious for you, just to say, I want Charlie, good one, no charge. Yeah, I've not had a fresh, I've had old burned out BK. I've not had a fresh BKH.
And apparently, like the book says something about Native Americans. Every time I see it, it's an African American. Every single time.
same with.
I was told.
You've seen more than one.
I thought it was like,
I'm like super jealous.
and obviously it's from Japan, so go figure.
But BKH is very simple, if I've ever seen. All right, go ahead. Madeline.
Okay. So patient had 6 months of no treatment. Their visual acuity did increase to 20/20. And these are kind of their incremental OCT max followed over 8 months.
You really botched this. Pavin's dictum, which is Pavin's dictum.
You gotta treat the patient before they get better on their own.
Right.
Otherwise you can't claim for
Right.
credit.
No, you can't, no.
You can get stuff.
Right, that's
Drop.
Pavin's.
Credit every other
You
day.
gotta move quick with your.
Artificial tears.
But I didn't think this was better. I mean, this isn't really better though, right?
He's 20/20,
Yeah, but he's got fluid.
so.
Yeah, it
Well,
seemed to
that's-
get better for a few months and then maybe worsen and kind of move inferiorly. Seems like the
Right.
fluid kind of came back a little more inferior to the original serous fluid, but
What's the most important thing to do here?
What's that?
DDT?
No, this is something you gotta do. It's something you learned in medical school before you knew about ophthalmology. First thing you learn in medical school to do.
Get a history.
Yes,
Yeah.
but what's the history you want?
Or steroids.
Forget the stress.
Yeah,
I mean, I
steroids.
should be blind, okay? So,
Yeah.
Type A personality.
I mean, give me a break.
Yeah.
Type A? Well, you don't seem like you're type A.
Yeah, well, I should be blind, you know.
Yeah, steroid use is
It's
important.
steroids, and what in particular do people forget?
Inhaled steroid.
Yeah, they're over the counter.
Nose sprays.
Yeah, it's over
Yeah,
the counter. All right, he'd had none of that.
so here's the OCT 8 months after his initial presentation.
Still 20/20.
Yeah.
Did he notice it? Does he have like a little?
I think he's not quite right. He's bothered by the spot.
He is.
I think. I would think.
Okay, so it's pretty similar. And here's another FA of the right eye and the left. I don't know if you want to talk about it. There's a little bit of leakage versus pooling here in the supratemporal area.
So what's this showing? This is an this is an ICG. What do you see there?
So there's an area of like hyperreflectivity,
Hyperfluorescence.
fluorescence. Surrounded by areas of hypofluorescence.
And ICG can be helpful with central serous because you're looking at choroidal leakage. When you're reading the ICGs in central serous, it's like 2 to 5 minutes, more like 5. Do we have another one?
No.
Okay, must not have shown much. So generally the first couple minutes doesn't show you much. The last 15 minute to 10, 15 isn't that great for central serous. It's good for AMD. But about 5 minutes in, you'll sometimes see leaky patches of the choroid, and that's probably where your problem is.
And if you did PDT, you'd hit them
Yeah,
here.
you'd want to hit where the ICG is leaking.
Well, you suppose, I thought, when I.
And the
when I
floor,
treat-
it tends to be the same.
You're supposed to hit where the choroidal vessels are dilated, and I could never define that. I could never, I mean, I could do something here, but is it my imagination? But I would, if I had the pointer, I would show you where I would treat based on the first photo. But, you know, that's what the
Right
paper
around here.
says. And, let's see, over here, so I would encompass that, maybe as much as that, and then I'd probably say, no, I really don't want to do that. So I'd center on it and probably be pretty broad in it. It's not an innocent treatment. If you lose track of time and you overtreat, they're gonna see poorly. And this is a 20/20 eye. You need to be. Yeah, I once overtreated and I didn't get sued, thank God.
The central serous?
Yeah.
Okay. I've never, there was a paper just came out saying subfoveal treatment for low dose is safe. But apparently it's not completely true.
If you lose track of your
Yeah.
timer,
But the timer shuts it off.
yeah, well, for
So
some
yours not
reason,
shut it off?
I overrode it. I forget
Oh.
why. I was probably losing my view or something,
Okay,
and so I lost track of
oh,
time.
because mine shuts off. I mean, I can't.
Yeah,
I can't
any
physically
3
shoot
seconds,
that.
it's supposed to shut off.
Yeah.
But it's, so, you need to, you know,
All right, good job. Keep going. You're doing
Yeah.
well.
Okay, so the patient did get PDT about right around when that last visit was, full strength, non-foveal. And just to clarify, is this kind of the area that you were treating here?
Yes, if you go back a slide, it's my circle. Back one. or two,
Ah,
right?
okay.
oh,
Okay.
okay, so you.
If you see one of those
a smaller
circles.
Area than I would have done.
Yeah, I do
Which you're
smaller.
than I am.
I do higher, like I do higher. I do, if I can get non-foveal, I'll go full on a central serous.
Did you cut the dose of the
Full dose,
diagonal, or you
full.
cut the?
If I was cutting, I do the dose based on you. That's standard of care now. You
Really?
thought, yeah, Dr. Page
So I was
thought
ahead of
that.
my
You were
time?
ahead of your time.
Yeah.
You were initially when everybody's doing half power, you go, that's stupid, do half dose. And now when you read the papers, they're all half dose. I think so. But anyway, if I'm non-foveal, I'll do full strength, full dose.
Okay, and then this was their OCT 2 months after that. So you had resolution of that subretinal fluid. There's maybe some lipid exudate here. Or is that just kind of from the
I think
PDT
it's
itself?
just where that's a funny image on it's probably not lipid.
So does the PDT cause like a scotoma like laser would?
It should, no, it's not
Should
supposed to
not.
cause anything. Supposed to be able to treat foveal, and in the AMD studies, when we used it all the time, there was a 4% risk of severe central vision loss, which meant 96% of people didn't suffer at all from it. So it's pretty, that's at full dose. If you do half dose for central serous, the recent paper just came out a month or 2 ago, suggests that none of them had. I think they pulled out, I think actually it was from from some studies. They pulled out from actually controlled studies. It's found that the subfoveal group did fine. All
Okay.
right, go ahead.
So we're going to be talking about central serous chorioretinopathy. Pathophysiology isn't completely understood, but there is a general consensus that it's associated with choroidal thickening, which we did see in this patient. From what I was reading, they think it has to do with hyperpermeability of the choroid, which increases the hydrostatic pressure in the choroid, and that can lead to venous insufficiency, which causes RPE barrier dysfunction. And so you get subretinal fluid accumulating in the subretinal space, and you can get serous retinal detachments. And they've also shown that they have choroidal thickening even in the unaffected eye, as we saw in our patient.
Good, keep going.
And epidemiology. So it's the 4th most common retinopathy behind macular degeneration, diabetic retinopathy, and branch retinal vein occlusion. It has a male predominance at 3 to 1 and generally affects young adult males 35 to 55 years old. There doesn't seem to be a racial predilection, and steroids have the strongest known association. So we classically think for endogenous steroids of this type A personality, someone with a lot of underlying anxiety or maybe going through a recent life change. But also important to think about endogenous steroids in terms of Cushing syndrome. So looking for like a buffalo hump, violaceous stretch marks, or significant abdominal girth. And then other systemic associations with elevated corticosteroids like hypertension, obstructive sleep apnea, and pregnancy. And then also considering exogenous steroid use, and particularly people who are on chronic steroids, such as those who need chronic immunosuppression, like people who have organ transplants or autoimmune diseases. It doesn't seem to be associated with intraocular steroids, according to BCSC, although it is associated with basically any other exogenous steroids, like even intranasal sprays. So
I have a case with intraocular, so
Oh,
I
do
know
you?
that's always everywhere, yeah, but I think it's very rare.
Okay. And then it's interesting because it's an inflammatory, non-infectious choroiditis that's worsened by steroids. So usually when we think of choroiditis that we don't want to use steroids on, we think of an infectious etiology, but this one is unique in that steroids worsen it, but it's not necessarily an infectious process. However, there's been a growing body of evidence showing that H. pylori infections may be associated with it. And they've shown in several studies that treating underlying H. pylori infections can actually expedite the resolution of their subretinal fluid. And in one paper I read, it was 2.5 to 2.7 fold increase in the incidence of CSCR in patients, or in H. pylori in CSCR patients compared to the general population.
Yeah, a lot of those papers, there was a window of time where H. pylori was being associated with everything, kind of like sleep apnea now. So there were some papers that came out then. It's kind of not very thing you check for now, the H. pylori.
I want to protest the explanation of the hyperpermeability, et cetera. The choroid is a sieve. So
Yeah.
I don't see how you get hyperpermeability in a
Well,
sieve.
no, it leaks more than it should. There's a balance, it's out of balance. It's
I'm gonna say that we don't really understand this disease.
yeah.
And that explanation is so diffuse and hard to remember. And I don't understand what it's saying, and I don't believe it. That it's just easier to remember, yeah, this is the disease where you get this the pattern that we see, and I don't know why. And
Yeah, people are trying to
admit I don't know why.
There's a lot of
because
work. There's
because
work
maybe we can find something because we admit we really don't know why.
Yeah, people, there was a couple, there's been genome-wide associations. There are some of the AMD genes associated with central serous. There's the paper came out in the last 2 months where someone looked at, you can look at choroidal outflow using OCT angiography of the choroid, and in central serous patients, it seems to be more segmental, like it was a weird paper. So I think there may be like a venous problem with these eyes.
So that tells us we still don't know.
Yeah, we still, yeah, there's a lot of work, but I have a feeling in the next 5 or 10 years, someone, kind of like MacTel. I thought that 2019 paper really nailed MacTel. I think someone will get central serous in the next 5 years.
That'd be nice. I wonder if I'll see it.
With your carotids. Go ahead.
Okay, so
Madeline.
patient, they'll often present with sudden onset of blurry vision. They may have a hyperopic shift due to the anterior displacement of the neurosensory retina. And they can also get metamorphopsia, paracentral scotoma, and they may have a decreased contrast or color saturation. However, their visual acuity can be very good. It varies quite a bit, but oftentimes they can be 20/30. And I'm not sure if that's just because they're kind of using the outside of their central vision to look at the chart. On presentation, though, when you look at their eyes, if it's acute, you can see this round elevation of the macula. However, if it becomes chronic, you may only see granular RPE changes. And diagnosis, OCT has been really useful in helping to quantify the amount of subretinal fluid and choroidal thickening with the fluid loculation, so you can track it over time. And as we saw in the FA, you can get leakage from the RPE. In the acute form, there's this dot or expansile dot, which we saw in this patient, versus the smokestack where you see kind of the subretinal fluid and then it kind of drips down into a larger space.
No, you got that backwards.
It leaks up, the
It leaks
fluorescent
up
goes up.
because of temperature.
Yeah.
It leaks up.
Oh, okay.
There's a density gradient, it leaks, yeah. it leaks.
I think,
Oh,
are you
okay.
talking about guttering? I think we should.
The smokestack, the smoke,
Oh,
yeah, if you look at,
The leak is at the bottom of that mushroom.
right,
It's at the bottom of the stem.
Oh,
yeah, keep Madeline, you're doing a great job, sorry.
And then it goes up because you said of
Yeah, it
temperature.
goes up.
Okay.
Yeah. It's not, it's actually, it's a concentration gradient. Because the subretinal fluid's denser on the bottom. And so there's a constant, it's like running a gel for the, I think the fluorescein goes away from the concentration gradient.
I see. Okay. Interesting. On autofluorescence, you can see leakage due to the shed photoreceptors, outer segments, and you can see them as well in the subretinal space, which we saw in some of those OCTs. And you can get these descending tracks, which you see here in this photograph. And then ICGA, you can see choroidal vascular hyperpermeability. And they think that the white dots on the surface are due to macrophages that have phagocytosed the shed outer photoreceptors.
Okay, cool.
And treatment, usually you start with observation, and if you're able to discontinue or reduce steroids. However, oftentimes we're not the people prescribing these steroids, especially if they have systemic diseases that warrant steroid use. It can be difficult to get them off of them. But if you're able to, discontinuing or reducing the steroids can help expedite resolution. If they do have a hyperopic shift, you can help with their vision, just get with some simple hyperopic correction. If the patient has chronic CSCR, so greater than 6 months, or if it's recurrent, or in a patient who's monocular, you want to strongly consider treatment. Usually first line is PDT, where you give the verteporfin and then you apply a specific wavelength of light to target the photochemical reaction resulting in this thrombosis. And you can use FA or ICGA guided technology. As Dr. Cohen was saying, you can get reduction in vision. And what I was reading, it's 1 to 4%. And also another major side effect of this is photosensitivity. So patients should try to avoid direct sunlight for a few days following treatment. They can also develop secondary choroidal neovascular membranes. And from what I was reading, it can be repeated in some instances if it's extrafoveal. And you can use half fluence or half power, which reduces the possibility of these side effects. But you can also do full fluence at half time is what I was reading. So 41 seconds instead of 83 can also cause a reduction in the side effect profile.
And what we were talking about was giving patients half the dose.
Oh,
So you
half
can
the dose.
you can give them half the drug and do full with everything else.
If they walk out into the sun after that, they will peel their skin.
Yeah, you can't, sun
It's
exposure
very
is a hard no, it's not, it's not an.
I had one guy,
Yeah, they
after I
can't.
did phototherapy, he got arrested because, he was pulled over because they thought he was a terrorist just shortly after 9/11.
Oh, he's still wrapped up. Yeah, there was, so the photo, in the dye makes you sensitive to red lights, so sunscreen doesn't work. And, all right, keep going, you're doing well, we gotta get to Nadia.
You can also do subthreshold
definitely.
micropulse laser photocoagulation, which is thought to stimulate the RPE cells to help resorb the subretinal fluid. And there's variations and opinions on mineralocorticoid receptor antagonists. I'm not sure what your guys' opinion on those are, but I saw some studies indicating that they were helpful and other studies indicating no difference between that and the control. So I'm not really sure what you guys usually do with that.
All right, and then what else you got?
That's just a prognosis. So 50% of people have persistence of the subretinal fluid at 6 months, and 30 to 50% will have recurrence. Also, 20% of those people who are over 50 also have coexisting choroidal neovascularization, and there's thought to be an association with polypoidal choroidal vasculopathy. And it's possible that they're actually related entities and maybe on kind of the spectrum of the same disease process, with CSCR being kind of a further stage of the same disease. That's it. Those
Excellent
are my